good morning, guys. I'm Lucas. I know you guys didn't meet me yesterday. I'm one of the neurointerventionists here, neurologist. So I'm going to talk to you about brain AVM embolization, planning for the procedure, and techniques. I want to thank Adam and Errol for having me here, and for you guys for coming. I think it's a great course. We'll just hit the road here. So, a couple of consultantships. So, just quickly, I think you're not going to hear me talk about Aruba. You're not going to hear me talk about natural history, but you do need to know, obviously, when you're choosing a technique, when you're planning, why the heck the patient is in front of you. And I think these are the basic reasons that we see patients with brain AVMs. Okay? This is nothing to do with this audience. But keep it in the back of your mind, and when I present cases, what I'm really going to do is run through cases, through different techniques. Potential marking grading system. Again, it's a common language. I'm a neurologist. I have to be able to talk this common language with the surgeons. But it does, when you do an endovascular, hopefully intranidal embolization, it doesn't have the exact same applicability as doing a craniotomy microsurgical resection. But it's important that we understand it as neurologists, radiologists, or interventionalists. But this is what we really need to be masters of. Again, you've heard the other faculty say this, the anatomy, the analysis of the angiogram. So there's lots of different things up here, but from my perspective, when I do an angiogram on a patient with an AVM, every single one of these things, I have to check these boxes when I'm done looking at the AVM and say that I understand each element, because it's going to come into play whether it can be treated and how it's going to be treated. All of these points are incredibly important. I'm going to try to illustrate some of these through the case examples and just use some individual pictures. So here we have two very different AVMs. Ruptured AVM, middle surgical, primary supply. Most of the drainage is cortical. I look at this, and this is a compactitis, but it's in a very eloquent location. Okay? This is a woman in her 50s who has horrible COPD, and she actually died of a PE before we could even treat her. Okay? Here's a young woman I've seen in my clinic. One of my partners saw 10 years ago. Incidentally found migraines. And she has this horrible AVM. Here's a vertebral injection. Diffuse nitis, pica, massage supply, obviously deep venous drainage. And when she presented with headache. 10 years later, she has a horrific hemifacial spasm that doesn't respond to anything else. You'll see why. Here's her external carotid artery injection. Massive middle meningeal, occipital, transosseous supply. And then when you look at this AP picture of the external carotid artery, what you realize, if I stop this for you, let me. About there, and you think about the AP picture, now you're seeing the whole AVM. It's a puzzle that needs to be put together, right? You don't fill all the AVM from this injection or from this injection. You have to put it together in your head. That's why the angiographic analysis is so important. I think when Joey was talking about Gerald Fischel, he said, we sit down, we look at the images. Tibor sends the patient home and sits down. I mean, these are complex problems. You can't just shoot a couple of pictures and now I have my plan. You really have to sit down and understand it all. So, and lots of times we learn a lot about what's going on with this patient, not just by looking at the angiogram. The cross-sectional imaging is equally important. So you're hearing kind of a theme. What's the patient presenting with? What is the anatomy? How am I looking at the anatomy? I think Joey's illustration of the flat panel CT was phenomenal because he merged everything, all the information that he gathered. With the technology that we have these days, you have to do that. So this is 10 years ago. Sorry, this is 10 years ago. This is now. So what catches my eye in this MRI is that the veins are massively engorged around the medulla of our tons, right at the exit on the 7th nerve. And why are the veins bigger? She's thrombosed this vein, right? There's venous disease. This isn't just an artery going into a bunch of tangles coming out. It's an active disease process that can change over time. So these kinds of cells are important. Okay? So just to give you a flavor of how we at the University of Tennessee, Sims Murphy, kind of looked at AVMs and what are our methods and goals of treatment. And Adam, correct me if I'm wrong or you think differently, but when I thought in my head, how often are we applying what kind of treatment and what are our goals? I think most of the time if we're doing pre-surgical embolization, we're doing it for cure. Okay? Curative embolization is very rare in our practice. We don't attempt to do that very often. Embolization or radiosurgery, this may even be generous. Stage radiosurgery, again, this may be a generous number. And palliative targeted embolization is also very rare. And this for us, I said I wouldn't say Aruba twice, but I'm going to say 3 times, I guess. This hasn't changed for us much after Aruba. Our stance has been if you're going to go after an AVM, you really want to try to cure it. And microsurgery with embolization is our preferred technique.
So let's take a minute to talk about that. There has been in the past a school of neurointerventional thought that primary embolization, curative embolization, ought to be embarked upon for AVMs. It can be used as a major treatment modality. And that looked pretty bad in Aruba, and I have never been very happy with that kind of result. But there are papers in the literature that suggest that for an AVM, you can just go after it, embolization, and there are certainly practitioners, particularly in Europe, that's what they do. You know, the AVM patient may not even see a surgeon. You know, Lucas and I may be giving you a distorted view, so if there are other faculty who want to comment on that, since we're talking to an embolization audience about AVMs, do you think we're off base? You tend to agree?
I totally agree. I think this, the way I like to think about it is what if I'm the patient, how I would want to handle it. And I think I totally agree with the approach that you have a short period of very intensive treatment that is aimed at curing the thing. So you do an embolization, followed shortly thereafter by surgical resection, post-op angio, you're done, and you're finished. And I agree that embolization, to go for a cure, I feel always very insecure with that idea. And as I said, unless the AVM is really simple, one feeder and one vein, which doesn't even need embolization most of the time, I don't think you cure. Now, but my question to you is that, this transvenous moraine thing, I mean, I tend to kind of shy away from radically new things until I understand them. And my understanding of AVMs is you stay away from the vein until the last moment, right? That's what you do surgically, and that's what you do with embolization. So, to me, to go through the vein and start your embo in the vein and then reflux into the nidus and claim that you embolize the entire nidus, and then you do a control run from an arterial thing, and if you don't see anything else from the arterial side, that means you're cured. I don't know. Is it all hype? Is it somebody trying to maintain his great stature in the world of neurointervention?
It depends on the AVM. I mean, if you have a small AVM, we've all had them. They're very small, they're very rare, the ones that you can actually cure. And even then, and I agree with you, I'm still nervous about those down the road. We don't really know. Do they recur? Do they, some people, we could do a poll of the neurosurgeons. How many times do you get cure and you still go to the OR and you take it out? I mean, it's a whole nother, but if you're going transvenous, that's a game where you have to have all your eggs in one basket. You can't leave any arterial supply and not have venous drainage, because 12 hours you'll get a hemorrhage on the side.
I agree. I just don't see how they promote that.
Yeah, I would totally agree. I mean, unless you get all the arterial supply taken care of, that AVM is still a living, breathing monster that can erupt. And I would just go in transvenous just doesn't make any sense. I mean, we've all had, like Daryl just said, the small simple AVMs or the right frontal AVMs that may be big that you can just go to town on because you know you're not going to hurt them.
Not only that, there's always, even AVMs that look incredibly well embolized, if you go in and actually resect them, like any sizable AVM, there's always little tiny deep perforator feeders that you're taking out at the very end, like on the underneath side. I don't see how those go away necessarily.
But you will run across, it sounds like unfortunately we have a fairly uniform faculty opinion, but you will run across people who really think of an AVM in different terms, and they'll say, well, it's 80% embolized, which is 80% better. And I just don't think that's what AVMs are like.
It's 80% better for radiosurgery.
Well, I don't even know if that's true.
Yeah, maybe not, but I think it may be 80% quote unquote safer for surgical resection, you're thinking? I mean, I don't know where that concept comes from, because if you get 80% of the AVM, it's still AVM.
I will still see patients referred in who've had a previous treatment somewhere, and the interpretation from the endovascular procedure will say, dural AV fistula, 80% of the arterial supply is gone, it is 80% cured. AVM, 80% or 60% embolization, like you're eating a pie and you eat a certain amount of it, and
I don't think there's something wrong with saying 50 or 60 or 80% just in terms of context, but in saying that cured, there couldn't be anything more wrong than that. So there's no such thing as partial cure or anything like that. Quantifying how much visually you've embolized
How much radiographic hit.
There's literature that suggests if you take over a third of the AVM, that there's a higher likelihood of So whenever I dictate, I say, it appears in 20% of the flow. But that doesn't mean they're cured. They still need to have their subsequent treatment.
Right.
And it's just a way to keep track of what you've accomplished at that time.
Yeah.
The issue is that you certainly, we have no, plus there were people who be like, well, I took out the part that looked dangerous. And unless you're talking about an actual nidal aneurysm, we have no idea what part's dangerous in an AVM. At least I'm not aware of that. Does any of you guys have insight as to what the dangerous part is relative to the rest? So
one other thing that Lucas was, we don't want to hijack the talk too much, I know you want to keep going. We have. But faculty interaction's good. Lucas said this, but I want to make sure you guys got it. I think the venous side of an AVM is about 3 times more important than the arterial side. And there's stuff in our specialty where we spend a lot of time paying attention to arteries. But when I see AVMs that have become symptomatic or AVMs that have been ruptured, when I really look carefully, I would say in 2/3 of cases, there is new venous restriction or venous stasis when you look carefully at it. And so I think, for me, I have to really force myself to look carefully at that vein side and try and understand it. And I'll even say I go further, and with an AVM that I'm looking at that's asymptomatic, I tend to be conservative if there seems to be no venous restriction. And if there's multiple veins, there's lots of blood that can get through there. I tend to get a little bit more nervous if on an angiogram this year compared to an angiogram 5 years ago, the veins are twisting and kinking and looking worse, because I think that's how they misbehave. I don't think it's a constant risk of 2 to 3% per year. I think they get into trouble with the vein side, and that's pretty much it for 2/3 AVMs. The other 1/3, I think they develop inflow aneurysms, and you get subarachnoid hemorrhage from the aneurysms. But I don't think a AVM nidus in and of itself creates any kind of problem. I don't believe in arterial steel. I think it's a venous congestion problem that gets AVMs in trouble. And I would ask you guys to look for that. And if you think that's wrong, come back and tell me, because that's just how my thinking has been evolving over the last decade. And Lucas mentioned it, but just watch it. Watch the venous drainage of AVMs carefully. Any comment on that before we give Lucas his talk back? Joey?
Hey. So, we're talking about tools and techniques, okay? So the lab is a great place to do something new. Your patient is a much more difficult and scary place to do something new. And finding the right opportunity to apply a new technology or just a new technique that you haven't used is it's picking and choosing your spots to take something from the boxing parlance. You don't want to be these guys, right? Any of you guys from the 80s, remember the 80s?
Anything happens to him, my people will be angry. To die in battle is glorious. To die in a tent is disgrace. And with that, I give you Dr. Julius Greenbaum. Thank you, Doctor. I'll just step out for a smoke. Perhaps I'll stay here. Today, we will be removing the patient's appendix. The first step in operation of this particular type is...
You don't want to be doing this. You want to know what you're doing the first time around, okay? So, I'm going to just try to fly through some cases. We all have different opinions on should things be treated. These have all been treated, so let's leave that alone, right? This is a 14-year-old kid with a corticoventricular AVM, pretty large volume, primarily cortical venous drainage up to the superior sagittal sinus. There's some deep drainage in the inferior sagittal sinus, deep venous system. Okay, so when I look at this AVM, it's pretty large volume. If I'm going to help the surgeon who's asking you to do this embolization, I want to take out particularly the deepest stuff next to the ventricle where he's going to have to reach down. Okay, and I'd like a decent volume embolization. Okay, he's looking to have a dry operation. Okay, so you can see the Onyx cast. This was Onyx 18 with a marathon microcatheter. And we went to several pedicles from this frontal branch and this other frontal branch that comes off of right here, the pericallosal artery. Okay, very important that you do when you're doing Onyx. Onyx can take a while, right? You've seen that down in the lab. You want to do interim DSA. Don't someone else, maybe your fellow, maybe your partner is injecting. And what are you looking for? We're just talking about the venous system. You don't want to compromise the vein, right? So what if you fall short, you take the arterial pedicle, you don't get as much nidal penetration as you want. The last thing you want is to shoot into the vein before you've done anything with the nidus. Okay? And what's the limit of your embolization? You should have decided this before you started injecting. What's your maximum reflux? You need to get that catheter out at the end of the day. Okay? And so I'm going to show you some bad things that happened to me. So I will say, when we talk about techniques, my least favorite thing in intervention, I said for a while, was pulling the damn marathon microcatheter. Okay, I hated it. It made me nervous. I can tell you, when I first got here, I told them that. I was more used to seeing blue in my fellowship, but we've done Onyx as well. So, we're in our last pedicle, this embolization. We've done I pulled 2 marathons from this pedicle. Had another one here. 40 minutes. It's going on forever. We're pulling, we're letting go of the tension. If you guys have seen this, we're pulling, we're letting go of the tension. And it took a while. And it's getting more nervous. Not happy. It's not coming out. You've got to be patient. That is incredibly important in everything that we do. Be patient. Right? So this is also incredibly important. What do you do at the end of an embolization? You take a whole head run, right? You look at what you just accomplished or didn't accomplish. You sit, I remember this, I'll never forget this, going into the control room, sitting down and looking at this. And I don't know why we developed an audience that day, but there was a lot of people in the control room, and everyone was real happy because they were looking at the nidus. You were looking at other places too. And look what's going on here. This is cut off. What the hell happened? That's our question for ourselves. What the hell happened, right? We got the catheter out. It's out. But there's a cutoff. Did the vessel dissect? Is it in spasm? Well, I don't know. I'm going to go find out now. So I was able to have, first thing I did is actually shoot the vertebral artery. I didn't put that picture up. What did I see? Back around, right? Posterior pericallosal comes around and almost gets to this point, giving a slight bit of comfort, but I still need to get this artery open. But I'm able to pass the marathon past it, actually pretty easily, and we just gave a little bit of rapid heparin, and we got really lucky we got the hell out of it. Okay. So to me, this is a segue into talking about technique, and knowing the pitfalls of the technique, and probably what I did too long, because leave the microcatheter on tension too long and stretch the artery. Okay? Cause it to spasm and maybe form a clot, but we're able to get it open. So thankfully, we have new techniques. We'll have other pitfalls, but the development of Apollo, I think, is a nice step forward. The availability of Apollo has been out in Europe and other places for a long time, but the detachable tip microcatheter allows us a little bit more safety. But I'm sure you could do the same thing if you didn't watch your reflux. Reflux past the marker. Okay, so this is a young guy, comes in with this hemorrhage, posterior temporal lobe, intraventricular. He's doing well neurologically, does need a ventriculostomy, you can see his hydrocephalus. And just a point about timing. My personal take, what I was taught in fellowship, for the most part, for several reasons, is you don't need to treat these AVM patients the day they show up. I'll show you patients I treated the day they showed up, but not everybody needs to treat the day they show up. That has something to do also with, are there high-risk features? What's the presentation? Is it subarachnoid hemorrhage? Are you looking for an aneurysm, like Adam said? Or is this a parenchymal hemorrhage from, I don't know what part of the nidus? Okay. So I do always get angiography when they show up, because I want to know what I'm dealing with. Otherwise, I don't know whether I can really wait, right? So it's hard to see. You can see straight sinus. It's early. You can see it here too. Now you see this little tiny kind of, I don't know the proper measurements for a micro-AVM, but this is small. But this is also associated with a hematoma. I may not be seeing the whole thing angiographically. To me, that's another reason to wait. I have actually seen that. I don't have a demonstration of that. But if you've ever seen blue or onyx injected into a compressed AVM, you're injecting where you think it is on the live roadmap, then it's somewhere else. Did I rupture the AVM? Or is it an nidus that I don't see because it's compressed? That's not a situation I want to find myself in. So I think waiting is reasonable. I think we waited 6 weeks approximately to treat him. When we talked about surgery, not surgery, my plan and the way I do things as an endovascular neurologist is never to go out of the room. We talked about it already. This is, for the most part, a surgical disease. In rare circumstances like this, you may have an opportunity to perform an endovascular curative embolization. I do think those patients need follow-up. They need 6-month angiograms. And when they're younger, the pediatric population will take care of them. At the novo AVM, we'll do an angiogram 5 years later for those kids. But I'm always prepared with my surgical partners. They know I'm doing the procedure, and basically an OR on standby. And we're not starting at 5 p.m. Okay. So,
I have a question.
yes.
Have you taken to using the Apollo? Is it working well for you? Or?
My only case, compassionate use for this case. This is before it was out commercially. And the reason to use it in this case, I told you I hate pulling marathon microcatheters, and I was looking at this bend like this, where I just didn't want that traction. I didn't know how on top of the nidus I could be with my microcatheter. So, you can plug and push, but then if you travel a long segment, I just didn't, and I'll show you the detachment.
So I'll tell you, I'm interested to hear the other 5 because I've now done about 6 of them. And for a reason that I don't get, I've actually lost the comfortability of building the plug because they have not a single I've done one spinal where I built it, it was the 3-centimeter one and I felt like a 3-centimeter plug and I pulled it at the top. But for the interventional ones, 5 of them, not one of them is broken. And I have photos and like fluorescent videos of me having it under super traction, the marker clearly away, and pulling a lot and not popping. So now I don't feel comfortable enough to build a plug big enough to try that again because I was so disheartened by that prior experience.
Did you also find that it's less flexible than the marathon, so we kind of give up a little bit on how far you can get in terms of access?
I didn't reach that decision making, but that might be the case. But
I only tried to do one case, so
I never had as much of a problem with the marathon. I think the one time I had a problem was in an external branch where I just, it was my fault. I just let too much regurg happen. I was there for hours. And so I think if you're conscientious about it, the marathon is a great catheter. I think it works.
Particularly external, what's awesome is Scepter.
So,
If
yeah,
you haven't done Scepter plus Onyx, man, it shocks me how flexible and far you can get that balloon.
I've actually moved to doing secondary intracranial.
The only,
If I have anything reasonable, any reasonable access intracranially, I use a secondary
Yeah,
intracranial.
and don't get me wrong, I'm not trying to impugn the marathon because you should understand with the Apollo, it can also detach prematurely. So there's a time and place for everything. It's a device.
I don't mean to lambast the Apollo because it's way too new and I don't have, and there are clearly people who like it a lot, but I was just wondering if the other faculty had larger experience. So far, I have not had good experience with it, so I just didn't know if other people. I'm trying to figure out whether I should try it some more.
Like I said, my N is one, but I think this is, to me, was an example of a technology that had a place for a specific patient. I used it to good effect, and it could have gone horribly wrong as well. This picture is to show you, it's not very dense in contrast, but you need good microangiography to know where you are, and you should really work your way to the nidus. Here, there's a short distance to the nidus. I often take multiple microangio runs before I get to the place where I'm satisfied that I can embolize and also understand the situation. This is to show you, if we are going to embolize curatively, then we need to do what was discussed, which is take the arteries going in, take the nidus, and take the veins. Okay? That's curative embolization, and that's why I put this on top of here, because I really think we got the pedicle, we have the nidus, and we have the vein coming out. Okay? That's where I was satisfied that I was done. This kid's had, or our kid's 25, he's had a 6-month follow-up, it's gone, and he's going to have a 5-year follow-up. And there you can see the PCA. There's a detachment zone, which is well within that temporal branch. So that gives me a modicum of kind of comfort that when I detach it, it's going to stay there. But that's what I was really curious to see. And this is I got to give Adam his due. He helped me a lot. And so when we did this case, I hadn't done that many cases in Memphis yet. And I said, I really want to try this. What do you think, Adam? We discussed this in our conference. He said, yeah, helped us get the IRB to get the device, and I was pulling on it, and I was nervous with Marathon already. It wasn't coming out, it wasn't detaching, like you were saying, Jay. Adam came in and detached it and walked out of the room. It's good to have good partners, people that you trust.
He walked out before you did the next angiogram, right?
So, we just talked about, someone mentioned Scepter, so I think it has a place also. It basically allows you to do flow control. Some of us down in the lab yesterday tried to simulate flow control. When you wedge a microcatheter, it's not flow carrying the embolic agent, it's your finger pressing it and doing it. So I think this is kind of pseudo flow control, and there's a couple reasons why, and I'll go into that, but I do see a lot of pediatric patients. I like working with kids, so this is a child referred by one of the pediatric neurosurgeons, and cross-sectional imaging suggests there's something wrong. You weren't sure whether this is a DVA or an AVM. Get an angiogram, right? Be sure. It has implications. Obviously, correct diagnosis matters. So when you take a look at the angiographic images, there's clearly shunting. There's a nidus, and I would classify this as compact. It's kind of wispy. Okay? And always shoot what could potentially be the secondary supply to the AVM, right? Although this is a cuneate, it's distal enough, it's bridal occipital branch of PCA, it's close enough that maybe a distal ACA or MCA could go there. And unless you take the picture, you don't know. Again, microangiography. This is, I think, a good illustration of working your way to the nidus. Okay? Because this picture is incredibly different than this picture. Okay? If you don't pick this up, you're going to have a problem with your embolization. Does anybody want to point out what the big difference is in fellows? I heard somebody say opposite vessels. What else? Thank you. So that, if you take this out, if you get embolic all the way down here, you may be okay if you get some embolic here because there's going to be a patient lateralization. But if you get embolic down here, you're going to blind this kid. And that was our big worry. That's why the surgeon really didn't want to operate and wanted to see if I could embolize it. And honestly, I didn't know if I could because I didn't have these pictures from the diagnostic angiogram. This is from the day of treatment.
Lucas, did you do this patient already?
No. I don't do, kids, I think would be very hard to do away. I don't use monitoring. I have to trust the anatomy. I think we all have to trust the anatomy. And the other point is 4 frames per second is incredibly important when you're doing microangiography. You really need to understand and see the pace that things are moving, so don't be afraid to increase the frame rates. So this was a scepter case, and as Jay said, it's pretty impressive how far you can get the scepter out. This was a large artery leading to the nidus. So I was able to get the scepter out pretty far. There's a couple of points when you're using a scepter that I think is important. You have to confirm balloon occlusion. Otherwise, you don't have flow. Right? So you inject from below. So you need a catheter that you can inject through that's big enough. And in a kid, the 4 French system, you're not going to get a good injection. So you have to upsize to 5. And you have to be comfortable getting access in quote-unquote little people safely. But here you don't see the nidus anymore. The pedicle's included. I don't have a native image to show you the balloon, but it's inflated. And I would inject more than once and confirm that, especially if you have a time delay, you're looking at pictures, all these balloons can deflate, okay? And then a microcatheter injection with the balloon up. Why is that important? Anybody have some thoughts on that? So you inject with the balloon down, and you see the nidus. You see the veins coming out. You inject with the balloon up, and you may be able to, with your hand, force contrast through the nidus to other arterial pedicles, right? So you have an idea of what you're up against, literally, what the competing forces are, and why your embolization may not be complete when you think it is. And that's why you always go back and check the collateral circulation when you're done. So this picture is with the balloon up, and this is our onyx cast when we're done. Onyx 18. So again, and how do I know that I'm done? I've got the arterial pedicle. Is that playing? Gotten what I think is nidus. I'm not sure that's playing. No, it's stopping when I drag it. So what I want to see is confirmation that I'm in the vein. And just like when we were talking about fistulas, once I've got the nidus, I want to go sequentially, pedicle, nidus, vein. Just like when we were talking about fistulas, there you start to see a caliber change. And there I'm pretty sure it's the nidus, excuse me, the vein. So, and you're doing control runs. Remember, you're doing control runs. In this case, if you're doing control runs, please remember to deflate the balloon. You're not going to know what you've accomplished. Okay. So, change in technique. Well, sound's not working on this one, but can anybody identify this? From the 80s again? Yeah, it's the great. It's too bad the sound's not working. But he's got a nice 80s fro right there, which is nice. Okay, so we talked about not treating patients and waiting. This is not a patient you want to wait on, right? I think you guys can see this is a very sick patient. The guy comes in with ruptured AVM, multi-compartment hemorrhage. He's actually got some subdural. He's got midline shift, big parenchymal component, interventricular component. And, there's blood everywhere. There's probably some subarachnoid blood. And we're not surprised when we do our immediate angiography that he's got this. Actually, he had a CTA, so we can see this on the CTA. And you can see that there's probably some, and I think this is a good example of compressed nidus, too. There's a lot of mass effect. You see this early vein, but you don't see a big compact nidus, but I wouldn't be surprised if it's there. But that's not what's important right now. In my mind, this is a very high-risk architectural feature, the one that needs to be dealt with immediately. Okay. Obviously, we're dealing with this ICP crisis at the same time, and we have a plan to fix this and get our butts to the OR, okay, and decompress it. So, how are you going to fix this? What is the technique in this situation? So again, microangiography, very important. You're working your way there. You can see that pseudoaneurysm, but you can also see some normal blood vessels. And personally, I think you can inject an embolic from here. He's had a bad injury. You probably won't know. You probably won't know for a long time whether you hurt him with non-target embolization. And who knows how much he's going to recover. But I would say if you can get closer, because you want to be on top of the abnormality that you want to fix. And, our brains are so richly vascularized that if you do non-target embolization or proximal ligation in that artery, I wouldn't be surprised if it fills from another pathway, ruptures later. This is more along the lines of what I want to see right before I inject the glue. Okay? You're right on top of the abnormality, and you can get a result like this. I still leaked some glue a little out distally, but I know that I filled that pseudoaneurysm, and that thing's not going to bleed again. So, a little bit similar but different technique, and I guess I should point out a little bit about what was the glue dilution on the last injection. I don't want it to go very far. I'm right on top of the problem, so I'm happy with the 50% dilution, 1-to-1. It's going to set up quickly, and I just get my microcatheter out of there. I don't want it to fly. I just want it to fill that balloon. This is a little bit different. This is another ruptured AVM, and this patient, again, does well clinically, sent home to recover, comes back about a month to 6 weeks later, and angiography, a little busy over here, oblique picture, clear abnormality, but I would never really understand this AVM until I get to a picture like this with a microcatheter. This is a marathon. And even in microangiography, you should try to look at primary and secondary arterial supply, all the things that we talked about before. Your eyes will go here and see this. And you're like, this is where I want to put my microcatheter. But this goes to the AVM too. And I'll show you a picture of that, or a movie of that in a second. There's one projection of that actually. This one's probably that. Watch this. Can we turn the lights down a little bit? I don't know if you guys can see that. But this was my point about injecting hard and refluxing back a branch. When I inject softly at the beginning of the injection, you see this, and then a little harder, and it comes back, and you see that secondary supply to the nidus. Actually, easier to drag it. Projects. You can see it come back. There you go. Doing force and contrast through the nidus there. So, at the end of the day, it's still injecting glue from that location, a little bit more diluted. And I feel like I filled up the nidus. Some stuff leaked into the vein, which is kind of what I wanted. I wasn't sure that I'd be able to cure this, but I have very low threshold for the OR, as we've all discussed. You need to be confident. It's a ruptured AVM. You want to know that it's going to be cured. Okay, so this is something I appreciate the surgeon's comments on, but a small AVM may be difficult to find in the operating room. And one of the things that we do is here's the pictures before and after. So it looks like it's gone, but remember that secondary supply. You never filled up that branch. You never really penetrated the vein well. Even though we didn't see it, we took a Dyna CT to localize our glue. That can be married to your brain navigation in the OR, whether it's brain lab or stealth, to help resect this. So I think that's a technique that can be very helpful. Let me just fire through this last case and then open it up to questions. comments. So this isn't AVM pathology. This is beta-galen malformation, but it's a good illustration of high flow fistula embolization. And as you know, sometimes in a PL-AVM nidus configuration, there's intranidal direct AV shunts. Okay? If you find your microcatheter next to one of those, you're going to want to use a specific technique, which is similar to what we do here. So, I guess the last thing in terms of technique is catheterization. We were talking about kind of the pull, the forward tension, and the movement of the wire back and forth. So when you see that kind of tortuosity, first thing is what kind of microcatheter are you going to use, right? I don't think it'll be very easy to get a Prowler 14 to take all these zigzags down here, okay? And this is where I think the Marathon or the Magic flow-directed microcatheters can really help you get to these places. But those places are deep in the brain, and your wires can be spears in these situations, in these tiny vessels. So one thing I would recommend, and you can do this in any vascular tree, in the external carotid, catheterizing an aneurysm, if you can, lead with the microcatheter without the wire out. Sometimes you can get away with that, and in my mind that's safer. So we're already very distal, 180 turn, 180 turn, and then you can see what this Magic microcatheter is able to do if you just push it without the wire. Extrude it. You can do all that, and then what Dr. Hamilton mentioned the other day, you release that tension when you pull the wire back, and it'll travel even further. And do that slowly, okay? There's no rush, but you do that slowly, and now, boom, you're right in front of the fistula, okay? So, when you talk about high flow embolization techniques, we're talking high percentages of MBCA. You can consider a coil basket, but you're going to be limited. If you can only get a flow-directed microcatheter there, you're not going to be able to deploy coils. See where you want to say something? I use tantalum almost every single time. I will sometimes ask the anesthesiologist for hypotension and have them prepare to give Valsalva just in case you shoot glue out where you don't want it. And I'll show you an example of that. Image your syringe is just another visual cue for you. At the lab, we talked about injecting the sugar water under fluoro so you can see the conditions, especially if you change the blood pressure. And we talked about this already. You want to know your maximal reflux point. You want to be on a blank roadmap. So this is that embolization. Actually, this isn't that one, but this is one that doesn't go exactly how you want it. And what do you do when the glue starts to fly? So here's a microcatheter tip right by the point of fistulization. So look at this. This is not good. Glue's flopping in the breeze. So the right thing to do here is actually inject faster because it wants to fly away. Stop. And what you need to do is fill up that pedicle. So watch right there. It's going to get fatter in a second. Fatter, 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 fatter. Injecting faster. And this was an error on my part. This was high flow and it was only 60%. So I had to inject faster to slow it down.
Or coil.
Or coil. But again, this is so deep that the only microcatheter we get there is a Marathon. At least, maybe other folks can get bigger coiling catheters there, but I wasn't able to, and didn't plan to. So, similar situation. And one of the things that you'll see, compare the position of the microcatheter at the initial catheterization, then we actually back it up a little bit, because you know the flow is going to carry the glue forward, okay? And I don't mind having the microcatheter tip against the artery wall, because as soon as the glue hits, it's going to start to polymerize, and that's a good thing, because this is a very fat pedicle, and you'll see as the glue comes out, this one thankfully comes out at a better pace. is forward. There he goes. And notice how it kind of fans out as it enters the vein. That's exactly what you want to see. And then it's starting to reflux and widen and approximate the size of the artery. And now I know I'm done. Boom, take the microcatheter out. So, this is not a contest, so I can compare who's better looking, my kids or Jay's kids, and show some pictures. But this is to remind you that we're all kids. We love our job. To my daughter, you put her when she was 1 in my car, she wants to drive it. She doesn't know, she doesn't know that she's going to crash it, because she doesn't have a foundation to drive it. So, just like everybody else said, I will leave you with the idea that you need to understand the anatomy. We love to play with the toys. You need to have a foundation to adapt these techniques and start small and then work your way up. I've had the good fortune of really good partners and an environment where you can kind of grow into your skill set. And I would encourage you to look for that kind of similar milieu if you can find it, because that makes the job even better. So I'm going to stop there and thank you for any questions.